Great. Ready to go. Thank you, everyone, for joining the session. This is the second session in our Health System Resilience stream. My name's Edward Tonkin. I'm the Program's Quality Manager at THET. We've had a little bit of a technical hiccup this morning, and our planned chair, Rhoda Ali Ahmed, has joined us, but is having some issues with audio quality. So for the beginning, I will take control of the session, and then we'll see what we can do to help Rhoda join later, if possible. But by way of introduction, I hope many of you have been able to join our session yesterday on health system resilience. We had a great session exploring some of the aspects of resilience, and we had some wonderful speakers coming in and talking about particular threats to health systems and the way in which particular countries or particular partnerships have responded to that. We had a wonderful session about resilience in the wake of IDPs, internally displaced people, and refugees in Nigeria and Syria. We had a great presentation from Dr. Peter Waiswa about the Ugandan health system and its response to COVID-19. And we also had a wonderful talk from Dr. Sansan U about the situation in Myanmar and resilience before and after the coup, which took place on February the 1st. So we're following that up today with a session about some particular initiatives that partnerships have been involved in. I think it's a great opportunity to showcase some of the work that particular partnerships are undertaking and or are planning in order to help build resilience in health partnerships and in the health systems that they're working in. So I'm very happy to introduce the speakers that we have today. So with us we have Dr. David Musoki and also Linda Gibson. David is a lecturer in the Department of Disease Control and Environmental Health at Makerere University School of Public Health in Uganda, and is also a senior visiting fellow at Nottingham Trent University. He is the Uganda lead of the NTU and Makerere University Health Partnership and co-chair of the Community Health Workers Thematic Working Group of Health Systems Global, as well as chair of the Africa Academy of Environmental Health. And Linda Gibson is a professor at Nottingham Trent University School of Social Sciences and is involved in several research projects in Europe, Uganda, Kenya, Malawi, Burkina Faso, Nigeria, and the UK, so covering a lot of countries there. And her research focuses on health promotion and health systems, services and community development and engagement, as well as patient safety, to explore non-communicable diseases, all through the lens of the social determinants of health and using a socio-ecological model. So they're going to be presenting to us today and reporting on their project to enhance the capacity of community health workers on epidemic and pandemic preparedness and response in Uganda. Following on from that, we have Mark Mwanza. Now, Mark is an engineer, a biomedical engineer, and is working currently as a lecturer of biomedical engineering at the Northern Technical College, or NORTEC, in Ndola, Zambia. And he's also been a health technology management consultant with us at THET. So Mark has been working in the field of biomedical engineering for 5+ years, and began his career as a field service engineer with Sonergy Diagnostics in Zambia. Did his training in Russia before that, and later has worked under the Ministry of Health in Zambia and the Northern Technical College, where he's been working to improve biomedical engineering and health technology management across the country. And he'll be talking to us about a project, a health technology management improvement project that THET has been undertaking, and he has been working with us on in Zambia. It's a project implemented in 4 provinces across the country aimed at improving the management and maintenance of medical equipment, which I know is quite a topic that a lot of partnerships are particularly interested in. So I'm glad we've been able to get Mark in to talk about that. And then finally, we'll have a presentation in the form of a video from Marion Lynch. Marion is actually currently working as an honorary advisor at THET. She has 38 years experience of working in clinical, educational and leadership roles in the NHS and across the world, and has extensive experience in health systems development and partnership working. Marion is a charity trustee and director, has her own consultancy in quality education and research, and since 2000 she's held a senior leadership position, the NHSE and HEE, and worked internationally. Marion's going to be presenting about the vision for a new master's program for nursing and midwifery, which will help create the health systems that Africa needs for the 21st century, with the University of Global Health Equity in Rwanda. So we'll play that video of Marion's, and then she's unable to be with us today because she's out sailing around the UK at the moment. So in her stead, we have her colleague Judy Canyola, who is a registered nurse in Africa. She's chair for the Centre for Nursing and Midwifery at the University of Global Health Equity, where she's working alongside Marion and others to transform nursing and midwifery education for the continent, and ensure the role played by nurses and midwives is included in health decision making. Judy's the secretary of AFRI Health, the convening body for health professions education in Africa, and a board member of AFRI PEN, the interprofessional collaborative body in Africa. So Judy is here to be on hand to answer questions during the Q&A. So we'll go through the presentations in that order. And just a quick reminder that while you're watching the presentations, please do enter your questions into the Q&A section to the right of your screen. And when you're writing in your questions, please also do include the speaker that you're directing the question at. And then we will collect those and present them back to the speakers at the end of the presentations. So I think that's all I have to remind you of. Please also, if you're having issues with bandwidth, don't forget that there is a tab at the bottom with HD on it that you can press, and that should help the situation. So without further ado, what I will do is I'll invite our first speaker, Dr. David Musoki, if you could please share your screen, and thank you very much.
Okay, thank you very much. And thank you, David, for sharing that. You'll hear from David in a second. So very happy to be here at the conference, again, at the THET conference. Always a wonderful learning event to hear what's going on. We're going to be talking, David Musoki and myself are going to be talking about our project on enhancing the capacity of community health workers on epidemic and pandemic preparedness and response in Wakiso district in Uganda. Next slide. So just to give you a bit of background, this project is part of a partnership between 2 universities, Nottingham Trent University and Makerere University, which we've had for over 10 years now. And actually having that partnership has been really fantastic over the last few years, and we might talk about health system resilience, but we also talk about partnership resilience as well during this last period. So, but we've got a lot of experience now in health system strengthening and working with community health workers in particular districts in Uganda. And we've done quite a lot of work together over the years. The particular project we're going to talk about today was funded by the Global Challenges Research Fund. It was a bit of small funding, but it provided us with the opportunity to take something that was of particular challenge at the time, which is why we focused on pandemic and epidemic preparedness. So that was the context really of which we set up the work. I think as well, because of the pandemic, normally the UK partners would travel to Uganda and work with our Uganda partners in supporting the work. But we weren't able to do that this year for obvious reasons, for last year and this year. But we were very heavily involved with designing the project and supporting the implementation and monitoring and evaluation. So, and we've got a long history of working together. So that certainly came into play and supported the project. Next slide, David. So the project aim was to enhance the capacity of community health workers on epidemic and pandemic preparedness and response in Wakiso district, where we've done quite a lot of work over the years and worked with communities of community health workers, but this time with a focus on COVID-19, but also recognising that epidemic and pandemic preparedness is also a bigger topic, which would be useful skill base for the community health workers. So I'll hand over to David now, who's going to talk about the project specifically.
David, you're muted. Can you unmute yourself? Thank you.
Okay, let me share my screen again. I had to get off the earlier screen I was on. Okay, so let me open the presentation again. Apologies for that. Okay, so thanks again, Linda. And this project, as you heard, was focusing on enhancing the capacity of community health workers who we know are locally referred to as village health teams. And the history about this is that, of course, we realized that this particular cadre had not received prior training on epidemics and pandemics. And of course, with COVID-19, it really made it more relevant for us to actually engage them as part of the partnership between the two universities. So this particular project had several trainings that we took them through, ranging from introducing them to various epidemics and pandemics, ranging from yellow fever to measles to Ebola and many others, but also tackle some of the topics that we felt are important for them as they respond to ongoing and future epidemics and pandemics. So topics ranging from engaging their communities to contact tracing in case of an outbreak, but also how well they could communicate when they were responding to epidemics and pandemics. Not forgetting, of course, how they could protect themselves, especially from contracting whichever disease they are responding to. But also to note that in the current circumstances, we couldn't have such a training without having a particular interest in COVID-19. And this was a very interesting session, given that many of them had not had much prior engagement on the disease, yet they were expected to actually be involved in responding to the disease and supporting their communities wherever they were. So that was a very interesting part of this particular training. Those who were involved in the training were the trainers were health practitioners. These are health workers who are working in the health facilities that are in the areas where these CHWs are based. And these are normally the ones that support our initiatives whenever there are ongoing trainings. But also we had some World Health Organization staff from the Uganda office also participate in these trainings, especially bringing the expertise in psychology, but also risk communication, which we felt was very important. But also some of the university staff at Makerere also supporting some of the aspects of the training. This was a 2-day training that was targeting small groups of 30 to 40 under the circumstances. And at the end of the so many months of training, we reached over 650 CHWs. As many of you would know, in Uganda, these volunteers are predominantly female, and that was also reflected in the number of people that we were able to reach. But we were targeting all CHWs that were available in a health sub-district in Wakiso district, which is Busiro South, but we also engaged those in entire municipality, but also later on those in a neighboring town council, which is Chengera, still in Wakiso district. As Linda mentioned, travel restricted the UK team coming to Uganda to work with us, and that was a bit of unfortunate, but we still had them participate and support the activities virtually. But also the team having to train these CHWs in the ongoing guidelines and restrictions concerning how well you can engage different groups, including, of course, trying to observe social distancing, but also hand hygiene and so on. We had to also screen all participants for temperature and signs of COVID-19 before the trainings, which was quite challenging at the start, but of course we got used to it, and indeed it went on quite well up to the very end.
David, we can't see your slides. You just need to share the screen again.
Okay, I'll do that. I didn't do anything to the screen, but let me try again and see if I can have them up again. How is it now, Linda?
It's coming up. Yes, it's there. Okay.
Okay, thanks for the nod. So just show you some photographs from the trainings. These are different trainings in different parts of Wakiso, and as you can see, we endeavored to observe the guidelines of trying to ensure distance between the participants, but also, of course, face masks being put on most of the time. The trainers, as I said, were mainly from the district, in particular the health workers, but also for those of you who may see bottom right, the famous WHO blue jacket, that was a risk communication specialist from the from WHO who participated in this particular training, which, as I said, was a very good gesture to have WHO support us in the trainings. The top photographs are really some of the practical sessions that we had, including, of course, hand washing, which, as you would expect, is critical for COVID-19 and beyond, but also top left, using and wearing gloves and other means of protection, including vaccination and so on. But also bottom photograph showing some group discussions that engage the participants. Again, not very easy to observe social distancing during group work, but at least we endeavored the participants to have the face masks that were provided to them as part of the training. And the last set of photographs just to show that we, as always, ensure that we give participants certificates on completion of such trainings, which sometimes could seem something very simple and probably not that important, but for these volunteers, it means a lot. And we always ensure that they get these certificates on time. And it's actually a form of motivation, which encourages them to perform even better during the course of their work. So one of the things we do as part of our trainings is to carry out a pre and post training assessment, which is mainly to find out if there's any difference in the knowledge, especially among the participants before and after the training. And as you can see, the key elements that we assessed these community health workers before and after the training showed that indeed there was some improvement in knowledge, but also the skills they felt they had gained following the training. Of course, this is self-reported, so there could be, of course, misrepresentation, but it shows that indeed the CHWs felt that after the training, they were more knowledgeable in many of the aspects that we were keen on, including knowledge on epidemics and pandemics, including COVID-19, but also risk communication and engaging their communities, but also how they could protect themselves to prevent getting exposed, especially when they're responding to pandemics, including COVID-19, that they're currently involved in their respective communities. So in conclusion, just to emphasize that the training demonstrated improved knowledge among the CHWs following the training, which we expect that in their current practice, there's going to be a difference in what they do and how they respond to their communities. And one of the things we are very keen at doing moving forward is to carry out an evaluation some months after the training, which was, of course, carried out. The training was carried out this year. So later on there, hopefully, we could find out whether indeed there's been a change in their practice as part of the broader benefits to them and their communities. But also to emphasize that Uganda is currently implementing a community engagement strategy for COVID-19 response, whereby communities are at the forefront in response to the pandemic. And of course, given that these volunteers are the main human resource in their communities, having their capacity strengthened is important for them to be resilient, but also to have the community health system resilient enough to respond to such ongoing pandemics, but also future epidemics and pandemics. So lastly, to acknowledge the funders and all those who have supported our partnership and our work in Uganda and in the UK, including the Ministry of Health and the district that we work in, which is Wakiso, the project teams in Uganda and the UK, but also the other local partners, including the trainers, mobilizers, and the local leaders, and of course the CHWs who have been instrumental in our work, but also who have sacrificed a lot to support the health system in Uganda. So thank you very much, and looking forward to any questions at the end.
Great, thank you very much, David and Linda. That's really a really interesting presentation and well done. I think yesterday we had Dr. Peter Weiswer from Makerere University speaking to us in this session, and I think Uganda has probably quite a lot to teach the world in terms of pandemic and epidemic preparedness, given the experiences in that country. So thank you very much for that. I think I'll just remind everyone, please do use the Q&A function and write in your questions, and we will, like I say, talk through those at the end with David, Linda, and the other speakers. So please do put your thoughts in there. Okay, thank you very much. So we will now turn to Mark Mwanza from Northern Technical College in Zambia. Mark's going to talk to us about health technology management improvement in Zambia. So without further ado, please take it away, Mark.
Okay, thank you very much for the opportunity. Just a second so I can share my screen. Okay, can everybody see the screen?
Yes, we can. Thank you, Mark.
Okay, thank you very much. Once again, my name is Mark Munso from Zambia. I'm currently lecturing at Northern Technical College in the Biomedical Engineering Department, and I'm also consulting with that on the Health Technology Management Improvement Project. TET has been operating in Zambia since 2011, actively strengthening health systems, which include, number one, the development of a biomedical engineering diploma program at Northern Technical College, where I currently lecture at. And also they have implemented a health technology management improvement project in 4 out of 10 provinces alongside the Ministry of Health of Zambia. And I also think it is very important at this point to acknowledge the huge role that has been played by the expert consultant, Dr. Chris Moore, who came to Zambia after a long career with Philips Healthcare to work with that on both the development of the curriculum and implementing the health technology management improvement project. So basically, health technology management is simply the management and maintenance of medical equipment. As we all are aware, appropriately functional medical equipment must be available in adequate quantities to deliver health services effectively, and it is very, very essential it is a very essential component of health service delivery, and without it, patients cannot be properly diagnosed, monitored, even treated or rehabilitated. So as said, we looked at the HTM cycle, which has been shared with you on the screen, and we see that HTM brings together multiple stakeholders within health facilities and the health system to plan and budget for and procure, to install and commission, to train, to maintain, and to manage, and finally decommission and safely dispose of the medical equipment required for service delivery. And organization and execution of all of these activities that you see in the figure that lays before you requires skilled staff on both the technical and the managerial level. And instead, we had to ask critical questions to ourselves to see how and where we can build resilience to the HTM system. On the left side, you can see some of the questions that we had to ask ourselves when we're dealing with the planning, when we're dealing with the budgeting and the procurement of equipment, to see how well we can improve on these stages so that they can be improved in such a way that they benefit the HTM cycle. We looked at how well we're dealing with training and so on to see if we have skilled personnel, if we have enough of those personnel. We looked at the maintenance aspect to see what we've been missing in the terms of tools, test equipment, to see what data we actually have, and also overall to look at the policies that have been governing this whole cycle. So our main approach to solving this problem was through a DMAIC cycle, which is hugely known. And our findings was that the status of medical equipment in Zambian hospitals is really unsatisfactory. That was step number one, which was defining the problem. And then we went on to measure the problem, where in 2001, a needs assessment on medical equipment was executed by THET. And it was found that an average of 20 to 40% of medical equipment in Zambian hospitals was down in selected hospitals. That definitely means that there is, number one, a loss in financial value. If 30% of procured medical equipment is non-functional, 30% of the money used to procure it is put to waste. And number two, there's also a loss in clinical value. If, let's say, 30 or 40% of the equipment is not functional in a hospital, which means patients can only benefit from about 70% of the services that that hospital offers. And we also went on to analyze the data that we found. And then we noticed to say, these findings, from these findings, there was not enough trained personnel or suitable infrastructure in hospitals to manage and maintain the medical equipment that is in Zambia. And then which leads us to step number 4 on how exactly do we improve that. So our approach as THET is, number one, we temporarily provided employment and a hospital placement for graduated BMETs. As of 2017 and 2016, we already had graduates from the diploma project that we started with NOTEC and so on. And so we helped them by providing temporary employment and placing them into hospitals. And then in these hospitals, we set up workshops where these BMETs would have an efficient environment and a good environment where they could work from. And then number 3 is we had to also provide them with the technical tools, which means a tools box, a full equipped tools box, and also IT tools such as a laptop and also a MiFi and so on, and access to internet. And we also provided them with test equipment that they're going to use as they work. And then number 4 is we had to provide a mentorship program, which was basically the involvement of experienced biomedical engineers who have been in the field so that they could assist the new BMETs in adapting to the local circumstances to integrate them in the National Biomedical Engineering Organization. And one other major aspect is we also had to provide them with a spare parts budget, which would help them repair the equipment that was down to improve their medical equipment status. And then finally, we had to consolidate all of this with a 10 months e-course in standard operating procedures for BMETs, which will lead definitely to a professional and a nationally harmonized way of working. So we implemented this project, as I said, in 4 provinces out of 10. Those are Luapula, Muchinga, Eastern Province, and Southern Province. As you can see, the highlighted province on the Zambian map there. And then below those provinces, you can see the number of hospitals that we've been able to implement our project in. So what we basically did as we were offering this standard operating procedures is that we taught the BMETs how to organize the works. As you can see in the structure, we had maintenance activities, which they get to learn in college: the order acceptance, the decommissioning of equipment, corrective maintenance procedures, preventive maintenance, and also the user training. But we now had to consolidate that in terms of how can they work together with the data recording aspect, with the data analysis and the improvement proposals. So by the end of the day, we gave BMETs the capability of generating a medical equipment inventory, coming up with an activity report that documents everything that the BMET, the biomedical engineering technologist, is doing at their facilities, and then also helping them with generating procurement priorities for the facilities at which they were placed at. In 10, also coming up with a bottleneck analysis, the gap that they have been having from reaching the 95% target that we had, 95% medical equipment uptime that we had in our project, and formulating a medical equipment management report, which would in turn help management in making informed decisions when we're talking about medical equipment. So the major key performance indicator is the medical equipment uptime. And based on early experience gained during a pilot project, which was conducted in 2017 by THET with the support from CEDA, we designed a package of measuring to, how well we're doing in terms of medical equipment, which is the ME uptime. And from our target, what we had was a 95% medical equipment uptime as per International Federation of Medical and Biological Engineering. That was our set target. And due to time limitations, we only chose to only sample out a few of our findings from our project. And at the end of the first year of the project, which is on the left side on your presentation, there were a total of about 2,447 medical units, which were present in 16 hospitals and then we managed to achieve an uptime of 95.8%, which went above our target. And on the right side, you can see how we performed in 2019. The average medical equipment uptime results for new BMS that we introduced into our project show that they increased from about an average of 74 and went to 95% of medical equipment uptime, which was really really good. Sorry about that. We'll go on to another slide. So when we look at how we've been implementing our project, we also wanted to take a look at the impact of our approach. And from that, we look at, first of all, the value of money that we have achieved, which is equipment value is retained. We don't just get to throw away once equipment breaks down. We can still manage to maintain it. We have also noticed that there's been a reduction in procurement of medical equipment because now equipment gets to last longer. And then previously you could notice to say because biomeds were not part of the hospital management system, once equipment is down, there was no one to really diagnose and carry out troubleshooting, to only find out it's a simple problem such as replacing the batteries and so on. Hence, they used to buy new equipment, which was really bad when it comes to financial value. We look at the procurement decisions that are being improved by the BMETs when they are part of the management system. And then also, we can also see that management is starting to slowly put in a spare parts budget because they can see the effect that it has had on the medical equipment uptime. We look at the sustained service improvement, and we have already noticed to say government is investing in the biomeds across the country by providing employment for a number of them. Recently, this year, 2021, at the start of the year, the government employed about 200 BMETs across the whole country. And then we also have the SOP trainers and mentors, which have been very helpful to sustaining the project, even though it is coming to an end at the end of the year. And we also have training, SOP training, which is being overseen by MOH and also a local technical college and so on. We've got a large community now of biomeds, which leads to ongoing service improvement. And we also have a large pool of competent trainees to improve the impact of further capacity development. Lastly, we look at long-term resilience, which we consider when we look at the increase in equipment uptime. And number two, there's the facilities are more resilient now because there are fewer interruptions. Once equipment breaks down, we have in-house BMS who are going to respond in time and not wait for us to call for expertise to come through and then troubleshoot and repair the equipment for us. And then we also have the reduction of referrals of patients to other facilities because they could not access the service at the nearest hospital because of broken down equipment. And then we've seen a lot of economic benefits because of the services that are being offered in a specific facility because of the availability and the functionality of the equipment. And we also have access to better information, improving service planning when we talk about the reports that we've been generating through our SOPs and so on. To take a look at that, I'll just give a brief success on the aspect of our success stories that we got from practitioners and clinicians and so on. As you can see, you're welcome to take a read through the success stories. I'll just mention a bit of them. We talked to Sister Tamba, who says BMS have worked on a number of oxygen concentrators which have helped save a lot of patients through these difficult COVID times. And Dr. Tikawe, who says the expenditure of medical equipment has reduced, as previously when medical equipment breaks down, the hospital had to procure a new one and so on. The acting PhD from Lopula province, Dr. Katongo, said before the third program, we only had one person in the province who we could depend on to repair medical equipment. So we can see that the project has really done a lot. Most definitely, we've also seen a lot of challenges, which includes the lack of funding and support due to not understanding the importance of medical equipment. And then we've only implemented this project in 4 out of 10 provinces. So we've got a huge gap that we need to bridge. Next, we also have BMETs who lack adequate management, visibility, and status in the hospital. And hospitals also lack equipment, also lack adequate tools and test equipment to maintain the equipment and to ensure that it is safe for our patients. And then we also have inefficient planning and procurement procedures, which we'll have to look into. And we also need to allocate a certain amount or a budget for spare parts to maintain medical equipment. And we can also see that there's a lack of continuous professional development programs to strengthen the HTM. So our vision is just directly things that counteract the challenges which are on the right side. And because of the limitation of time, I'll definitely have to stop here, but we would definitely like to cooperate with other partners so that we can continue strengthening the systems and we can build the resilience in Zambia. Thank you, Edward.
Great. Thank you very much, Mark. Really great, informative presentation there. And once again, I encourage you all to, lots of claps coming up, which is nice to see. I encourage you all to go to the Q&A tab and put your thoughts down there for Mark to come back to. So yes, really great outcomes being talked about there, and obviously it's a huge part of the resilience of health facilities that they're able to perform the services that they should be doing so, and it's great to get that. What you said about value for money there as well, I think is a really big part of that. Okay, thank you very much. So we're just coming up to 11:30 now. So I will ask Daniela, please, to show the video that we have from Marion Lynch to talk to us about the Master's Program in Nursing and Midwifery at the University of Global Health Equity. And I see we have Judy here, so Judy will be on hand later to answer any questions that arise from this next presentation. So yes, I'll just say very quickly before the video starts that I filmed this video with Marion via Zoom, and while she was on her boat, which she's currently sailing around the UK with. So just to say, there are a few slight technical issues here and there in the video, but nothing that should harm your ability to hear what she has to say. Also, that unfortunately I left my video on while I was filming this with her. So if the camera switches to me occasionally, please do not be alarmed. But with that all said, please go ahead, Daniela, and play the video.
Welcome to our presentation outlining the forthcoming Master's degree in Nursing Leadership. This is from the University of Global Health Equity in Rwanda. This is designed to create resilient health systems by supporting healthy countries, high quality health systems, and a healthy, happy population. And we're doing this through the development of nurse leaders. My name is Marion Lynch. I'm going to present the work here. I'm helping design this and deliver this program, and Judy will be answering questions after the presentation. We start with the principle that health is a human right. We end with our proposal that nurses educated for and employed as senior health system leaders will make this happen. So why is this important? In Rwanda, health is a human right, and with rights come responsibilities. The Rwandan constitution says the state has the duty of mobilizing the population for activities aimed at promoting good health, and all citizens have the right of equal access to public services in accordance with their competence and abilities. Now, these systems support Rwanda's vision to become an upper middle income country by 2050. To get there, we need a healthy population and a skilled health workforce. As nurses make up the majority of the workforce and see most of the population, it seems sensible that investment in nurses to support the health and wealth of a nation makes sense. However, it's universally agreed that we need more nurses everywhere, and we need more nurses influencing policy and practice. Now, in Africa, we've got a few problems with this. The World Bank reports that our universities are limited in research opportunities, innovation, and problem solving. Plus, in Africa and across the world, nurses' work often goes unseen, and nurses as leaders often go unseen. We work below the radar. This means that the culture, the courage, the compassion, and the capabilities needed for leadership roles also are often unseen. Now, the University of Global Health Equity is addressing this problem through this master's degree that will in turn help create resilient systems, a resilient workforce, and resilient countries. So the context for us in Africa and across the world, but I'm particularly talking about Africa, is that nurses and midwives form the bulk of the workforce. This includes everything from prevention, diagnosis, and care. Now, if Africans are to access the quality of care they deserve and need, our nurses need to be trained and employed in leadership. However, there is a real mismatch between the rhetoric of nursing leadership and education and the evidence that we talk about in the global north, and the reality of putting this learning into practice. What this means is that nurses remain undereducated and under-resourced in LMICs, which creates an uneven power dynamic. And this power dynamic expands to issues with patient care as well as political influence. So our aim and approach is Ubuntu, This means I am because we are. Our nursing leadership master's degree will create nurses who will design and deliver healthcare that is high quality and compassionate, equitable, accessible and evidence-based. In other words, in a nutshell, we're going to be creating health systems fit for purpose for 21st century populations' health and countries' needs. Also for our nursing professionals' needs. And we're going to help nurses lead at all levels and be heard in all settings. Our aim and educational approach will be more than developing the competencies to healthcare, improve healthcare quality and health and well-being. We're going to build these capabilities and the credibility to make clinical and strategic decisions, not only to improve population's health, but our professionals' practice, and be heard at national policy discussion and direction-making events. We know that in education, you do this kind of thing by creating a culture of quality, of compassion, but also the skills of critical thinking and the societal approach of Ubuntu, I am because we are, this collective way of being. So this collective way of being will show through in our programs. We're more than a course, this is going to be a community. And by building a community, we build something that is sustainable and resilient. The 21st century healthcare needs will be matched by 21st century workforce design. We won't have nurses built upon a 20th century or a 19th century model. And we're going to do this by utilising science, arts, technology, and our imagination to develop the skills to lead and create complex systems. We take it in a way that we talk about nursing a strengths-based approach. This is different to the way that other education programs work that look at deficits, but we take with Gottlieb's model strengths-based approach. And we also take approaches that share and create knowledge, build networks, and create community of practice with the present and future African senior nurse leaders, and beyond that, world leaders. We'll therefore have an international local expertise and experience, user experience too, that uses the cultural and context appropriate evidence that we want people to build upon. We're going to learn face-to-face and online, and all the evidence on educational programs. We're going to have the reflective practice that enables nurses to learn more and build upon skills, the leadership mentors that develops these communities, the quality improvement projects that actually take theory to practice, and we're going to utilise the arts to learn, have placements and all the academic assessments that go with a master's degree. And this means that our content will create resilient people, resilient systems, resilient society, and a resilient planet. We build upon the work that's already gone on to develop advanced professional practice for healthcare practitioners. And this has evolved from African programs to look at what is needed in nursing, right through to Health Education England's work on what advanced clinical practice should be. And all of this says that it needs to be underpinned by master's level awards or equivalent that encompass all 4 pillars of nursing and other healthcare professionals. We're going to have all of this, but we're going to have more than that. We're building upon the literature in nursing leadership that originally has looked at patient-focused leadership and organisational and system leadership. We're adding in a 3rd level, societal-focused leadership. And this builds upon the University of Global Health Equity's work that examines structural violence, equity, justice. And we'll do this by incorporating thinking about ethics, environments, language, privilege and power into our curriculum. And these insights on the wider world of health and harm will enable us not only to examine principles and the evidence that informs aid and assistance, government and governance, finance and fairness, but also then to gain the skills needed to utilise these wider societal frameworks to influence resource allocation, research activities and regulation adherence. Additionally, we really want to make this culturally sound. So the evidence base we're using and the authors and resources used will predominantly come from the Global South, therefore addressing the cultural and colonial aspects that have been discussed in global health and in health professional education to date. This focus on where the evidence comes from and who the authors are will help us build appropriate communities and also also compassionate leadership, and embrace the concepts that we live to. So our programme builds on fantastic building blocks. Already the University of Global Health Equity has executive education for leadership, quality and equity. This isn't master's level, but we're going to take that basis and build upon it. We also build upon those principles of understanding where structural violence is and what our contribution is to that. We're building upon the Harvard Macy work on disruptive innovation, where we really can look at 21st century approaches rather than, as I said, building on old models. And we're also building on the Anglophone Africa Advanced Practice Nurse Coalition project, which pointed the way to nurse education for the future for Africa. The International Council of Nurses have given us a framework for advanced nursing practice, and the NHS Leadership Academy has given us the evidence and approaches to develop credible system leaders. There's no point having leadership programs unless they actually make a change to the systems that we're working in. So our work will build upon the World Health Organization's work on quality, the Institute of Healthcare Improvement across Africa's work on quality, and also the UK Health Foundation and NHS Horizon's work to improve quality. And this is, whilst we'll have quality improvement projects, we'll also build on social movement principles as well. Also, the fifth wave of public health will enable us to bring arts into our work and not only build upon the work of arts in health across the world, but also the University of Global Health Equity's programme on arts in health too. We launch in August, September 2022. So we really are inviting you to be part of our community to build and co-create the curriculum and the content now. We're having our first virtual meeting of international stakeholders and critical friends in December, and invite you to be part of that. If you are unable to be part of it, but have written or read resources that you think will aid our mission and stick to our values, please share them with us, particularly Global South authored work. And if you're interested in being in our first student cohort, please contact us too. Judy will now be able to answer any of your questions. And thank you from my boat. Bye-bye.
Great. Thank you very much, Marion, wherever you are at the moment, on your boat somewhere around the coast of the UK. So yes, really interesting talk from Marion there. And thank you as well for the questions that have been coming through for our panelists. So I think then we might turn to those. I have a number lined up here, and I think that the first one probably for David and Linda, I was thinking about as I was looking at your presentation coming through. Obviously, with the history of epidemic, pandemic, and so forth in Uganda, I'm just wondering how the training that you offered to community health workers through your project, is it something that has been done previously with other outbreaks? Obviously, there's been Ebola, cholera, other pandemics and so forth in Uganda. Was the work that you were doing significantly different in the context of COVID from that? And if so, how did it differ from previous work that may have been undertaken?
Thanks, Edward. Very good question. So actually, from our working with CHWs for a while, we actually confirmed that these volunteers had not had much prior training, even for diseases that are routinely occurring as epidemics, be it cholera and so on. So they've actually had very minimal training on this particular subject, and that was one of the motivators for us to seek funding to have them trained in this field. But in terms of how that played out, of course, as I said, the training had a session on general epidemics and pandemics, knowing that, of course, we expect to, you know, have a few of those more in the near future. Of course, we wouldn't want to, but from history, this could still happen. But we also had to make sure that although we had earlier looked at the broader epidemics and pandemics, we also have a component of COVID-19. And actually, to be honest, the COVID-19 session was probably more interesting to them than the broader pandemics, because that was something that they were interfacing on a day-to-day basis. And actually, that, to me, I think was one of the more interesting sessions, given that many of them had a lot of misconceptions concerning COVID-19, including vaccine hesitancy, but also, you know, what to do when they test positive, but also how to handle their communities in terms of their role in, you know, health education and contact tracing and so on. So that, for me, was one of the highlights from the training. Linda, anything to add to that?
Yeah, I mean, absolutely, I agree with David. Just to add too, because there's a slightly more nuanced question around challenges of working together in the partnership, you know, solely remotely. And yeah, of course, that was a huge challenge and a huge blow that we couldn't go out and work as we do with our community health workers. We've been working in the district now for 12 years, something like that. So so we feel very much, you know, connected to the communities, and we've had community health workers from Wakiso come to Nottingham and visit us and work with communities here and working, you know, with our partners, and so we feel very connected in to the communities. We keep very much in touch through social media. So WhatsApp is our main kind of mode of communication. And we do a lot of kind of like troubleshooting or quick decision making. If there's any quick queries or questions or things that need to be sorted out, you know, we're very quick in response in that way. And that is an absolute lifeline, I think, that enables us to make a lot of quick decisions, troubleshoot, that kind of thing. So also what David and the team do, which really helps us in the UK not to feel distant, is that we're constantly getting a feed of what's going on. So, you know, the photos are coming through, maybe little videos as well. Actually, at the top of the presentation, David has a picture of the team in a canoe going over to one of the islands where they, one of the remote communities that they work in, which I haven't visited those island communities as yet, you know, and David was teasing me about, well, Linda, are you going to come in the canoe? Well, you bet, you know, I'll be in the canoe next time going over to those islands. And so we stay very tightly in contact. And I think we've learned that very close and quick communication is really key, really, to decision making, troubleshooting, but also that feeling of being involved in connectedness. And also I hope that our community health workers know that, you know, we are there supporting the work and committed to the work and in for the long haul and not just the short term. Do you want to add anything to that, David?
Great.
No, that's fine, Linda, thanks.
No, thank you very much, both. That's great. Yes, we're all having to deal somehow with not being in so much face-to-face contact at the moment. But like you say, it's all about rowing together, as you will be doing when you next visit Uganda. Okay, great. I might, I'll come back to you, David and Linda. I might just quickly switch over to Mark. So a few questions have come in about your presentation. Louise asks, the importance of effective management and maintenance of medical equipment is often overlooked. What more can be done to convince policymakers and donors of their importance? And I might actually just add to that very quickly as well, from a question from Richard around what further activities or investment are required for uptime to be maintained into the future, in your opinion. So, yeah, what do you think about that?
Thank you very much. First things first, I think for us to be able to change policies, we need to first of all start with sensitization. I think that hasn't been done very well yet at administration level. So they really need to be sensitized so that they can be aware of the importance, and they can make sure they reap the benefits of having biomedical engineering technologists in their facilities. Most of them do not yet know the roles of a biomedical engineer. I can also add on to say that biomedical engineering has not yet been well advertised compared to other professionals such as doctors and so on. So I think one of the approaches we could also take a look at is using the media to advertise on such and so on, so that people can get to know what biomedical engineering is all about. One other thing I could also talk about is the employment aspect. Not till recently is the government able to create positions for biomedical engineering. Number one, they say funding has been a challenge. So for us to at least find the funding so that we could support putting these biomedical engineers, making these biomedical engineers be employed in the Ministry of Health system, that would really help on that, because the more they are adopted into the system, the more they get to see how visible they are, and the more they get to see how effective the biomedical engineers are. And well, I also think there has been a huge gap when we talk about how biomedical engineers work with the practitioners, because these are entwined. They're supposed to work together, but they always work as separate entities, which we need to now change. We need to have more programs where, if we're going to talk about anesthesia, we're going to call the anesthetist, and we also have to call the biomedical engineer, so that they are all aware of how they're supposed to work together to build the resilience in all of these systems. By the end of the day, what we have is a situation where we would have a conference on anesthesia, but only the anesthetist would go to that, only the doctors would go to that, and the biomedical engineer is sidelined. You see, so and then they expect the biomedical engineer to know about all of these new systems when they have not been well informed. So we need to create a situation where we have a joint workforce combined with the practitioners and the engineers. That's really one of them. Number two is well, I've already said a lot of points. I think this should be number 4 or 5. The issue of spare parts, budgeting, and so on, is a huge issue. So we need to change how policies are, so that the biomedical engineer is put as one of the most important aspects in the planning, because then you have someone who is specialized, so that you can counter such problems, because he knows about them. He knows at a certain point in time the equipment will go down. He knows that this type of equipment can easily go down in 5 years or 3 years. So we need to plan like this, and we need to keep so much money, so that if it is down at that point in time, it will only take 30 minutes for us to get it back to a functional status again. So there are those aspects that we need to improve on. The next question, Edward. I don't know if I've answered everything. If I haven't, please let me know.
Yeah, no, I think that was excellent, and I think the amount of thumbs up you were getting as you were talking through that was demonstrating that. So thank you very much. Point really well received, I suppose, about visibility of the profession, as many in the audience will well know. Biomedical engineers and/or people fulfilling that role are very often to be found in the basement somewhere, and not all that visible. So, yeah, no, thank you for that. That's wonderful. So I think we have Judy online now to help answer questions around Marian's presentation. So a few have come through here. Audrey asks, It makes so much sense for nurses to be involved and lead on the process of designing health systems and making strategic decisions. Why do you think this approach has not necessarily been put into practice in most countries up until now?
Thank you so much. I hope you can hear me. Yes, it's very true that nurses have traditionally not really been part and parcel of, being involved in leadership or such in the past. And this is, I think, just due to so many issues around past injustices in Africa. Certainly, we've inherited things through the colonial system, which we then inherited structures that put nurses in the back. I think even in the global north, issues of patriarchy, or where mostly because nursing is a female-dominated profession, we feel that they should not be at the table to make decisions and to be involved at that level. So nursing traditionally has suffered from that poor image that we are mostly seen as not decision makers, just sort of like doers, but not really should be involved in strategy and decision making. Poor leadership has certainly compounded this over the years. And you find still often leaders, people in leadership position are men, and they don't want to see, I don't even want to say men, but don't want to see nurses, because most of the decisions are physician-centered and don't really want that to happen for various reasons. I think another thing that has also contributed to this has been just ignorance around the nursing profession and the midwifery profession, and exactly what is it that we do that would then necessitate us to be at the table. So I think demonstrating that, and programs like the UGHE Masters in Nursing Leadership is going to equip nurses to then be able to actually bring to the table what is it we do, that people then realize, oh, aha, so we really, I can see the role that you play and why then we need to have your voice. And for me personally, as Judy, I've actually done this, literally like walked to people and knocked on their doors and said, I want a nurse at this table. And now over the years, I see that when people see me, they're like, sorry, Judy, yeah, I'm going to send you an email. We need a nurse. Because people actually just do this by, they don't realize, so sometimes if you make a decision, you don't even realize that there's something wrong. So I think myself and, all of us in this profession, if we all of us actually take up the mantle and do that, then we'll definitely see the change. I'll stop there, Edward. Thank you.
Great, thanks, Judy. It's really interesting how this session on resilience has become very much about visibility of different professions, and I think that's really great to hear, and it's great to hear that your initiative is going to tackle that in such a comprehensive way. We've got about a few minutes left. I'm going to go back to David and Linda very quickly with a question from B. So B asks, in terms of the system which the community health workers work within, how have they worked with higher level health facilities and the referral pathway in order to ensure continuity of essential services throughout the pandemic?
That's a great question. So the health system in Uganda is structured in such a way that the community health workers are the first tier of cadres, if you like, at community level, but these actually are supervised and report to the nearest health centers within their areas. So for example, all the reporting and all the communication from them actually goes straight to the neighboring health facility. So in that way, whatever they do in terms of a pandemic response and management, but also in their day-to-day practice, including treatment of childhood illnesses, is directly linked with the higher health system through the nearby health facility. And in that way, their information and their challenges and their reports is actually channeled right up through that health facility to the district health office, and from there to the Ministry of Health. Of course, there are challenges in terms of having that information reach the higher levels, but the structure is designed in such a way that there's that link between them and the higher levels of the health system.
Great. Thank you very much for that. We've just got a couple of minutes left. I might ask a question that's been put in for all respondents. So Audrey asks, how can we ensure resilience strategies developed during the COVID crisis can be applied or adapted to other crises and shocks such as climate disasters or conflicts? And how can we ensure that lessons learnt are not forgotten? So that's a nice open question, and I think I'll open it up to anyone who wants to come in and talk on that. David and Linda, is there anything that you would say in that regard?
And perhaps I can go just first. I'm going to link it to another question that Louise put in the Q&A, which is about learning and how partnerships can promote learning more fully. And I think it is actually about dissemination of our work is really, really key. And we're very fortunate, I suppose, because we're a university to university partnership. So there's a lot of focus on knowledge exchange. But I think knowledge exchange, partnering up with groups where you can get together and exchange learning and knowledge is really, really important, and disseminating the work that you're doing and having those discussions, publication, conferences. One of the things we were asked to do in the UK and we put forward was around lessons learned from partnership working in Uganda. We put forward some evidence to the UK Parliamentary Committee, which was talking about partnerships and what they bring and the value and importance of those. So I think it is about looking for those opportunities for disseminating the work and carving out time for that. And I know that must be quite difficult, when you're in practice and in the role, etc. It's part of what we do in universities, isn't it? So, we have pressures on us to make sure we do that. But when you're in practice, but I think it is about, helping people carve out that time to have those kind of activities. Great.
Yeah, absolutely. And maybe, Judy, I don't know if you have anything you want to say on that area. You're muted if you are saying anything.
Oh. Can you hear me? Sorry about that. Okay. Yes, absolutely. I agree that some of the things that we are learning from climate change certainly need to be addressed and lessons learned not forgotten. I think for me, the other thing that I always find is that if we really get to the heart of why this is happening, then that's when we can make a change. But so far, I don't see that happening at all. There is an understanding from everybody that yes, climate change is happening, but and then the reason why it's happening is understood, but no change is being made to address that reason. So to me, sometimes I feel like we're chasing our tail. If we know, for example, that we do not need a coal plant or a coal plant in Lamu in Kenya, but because of structural inequities around, across the board, somebody wants to build a coal plant in Lamu in Kenya. And we know what that does to the environment. So then what are we doing? Because you're going to build that plant and then you know what's going to happen. So why don't you not build the plant to start with? If we know that plastics, for example, of a certain micropore diameter, etc., are causing harm and damage to the environment, then why do we continue to manufacture the plastics? For heaven's sake. So I think for me, we need to address the issues at their core or begin, because I know, of course, it's not an overnight change. But if we start, Rwanda started by banning plastics many years ago, long before people even were talking about climate change in Africa. And I actually came through the other day and I just had bought something in duty free, which I didn't realize was in a plastic bag. And they said, sorry, ma'am, that can't move. And they removed it, they took it out. They took away the plastic bag and binned it somewhere. So to me, I was like, this is it. So our policies around managing the climate change need to happen. So telling me as a nurse that I want to manage respiratory illnesses after you built the coal plant, to me is a bit lopsided.
Mm-hmm. Great. Thank you very much for that, Judy. I think we're now a bit past the time for this session. So please join me in thanking our presenters here today for their brilliant presentations and the discussion that we've had, the very stimulating discussion that we've had. I think we've now got a half-hour break, and then we have an experts in our mid session starting at 12:30. So please come, we'll go and have a cup of tea and then come back to that. And just a quick reminder to everyone to fill in the event feedback forms by the end of the day. Great. So thank you very much again to all the speakers, and I think we'll end this session here. Thank you very much.
Thank you. Thank you. Bye-bye.